Good afternoon, and welcome to everyone joining us here in Washington, D.C. and at the Office of Mathematica Policy Research, and also to everyone listening on the web. My name is David Stapleton, and I'm the Director of Mathematica's Center for Studying Disability Policy. This is the Center's 20th Disability Policy Forum. Now, some of you likely know our president, Paul Decker. He's a very cautious sort of man. He called me early this morning, and he proposed that we cancel today's forum just so that we wouldn't upstage the Supreme Court. He went on, he said, Dave, you know, what if we're a plaintiff or a defendant and our case goes all the way to the Supreme Court? They'll kill us for interfering with their publicity. I said, Paul, we've got 100 people coming, and we've got 400 registered to be on the web and listen, and surely the court will understand our reluctance to disappoint the public. So he finally agreed to let us continue, but he did ask me to do one thing during my introduction, so I'm going to do it. So if any of the justices happen to be listening, we want you to know that we're very sorry. We throw ourselves at your mercy. And just to be sure it never happens again, we've added your names to our email list, so you'll know the schedule for our future forums and have plenty of time to schedule your announcements around them. Today's presentations will address the challenges associated with coordinating care for the more than 9 million American adults who are eligible for both Medicare and Medicaid. Formerly, they are Medicare and Medicaid enrollees, but that's a mouthful, so they are commonly referred to as dual eligibles. Whatever you choose to call this group of people, it consists of many of the poorest and highest need beneficiaries in both programs, and their care needs account for a disproportionate share of spending across both programs. As Medicare and Medicaid enrollment and spending have surged in the face of shrinking resources, this group has drawn much attention from state and federal policymakers and program officials intent on finding ways to improve care, coordinate service delivery, and reduce costs. Today's panelists have significant expertise on the dual eligible population and their health care. We're first going to hear from Jim Verdier, a senior fellow here at Mathematica. He's going to describe the highly heterogeneous nature of the dual eligible population and the medical and financial barriers that make improved care coordination a very difficult challenge. Next, we're going to hear from Melanie Au, who's also a researcher here at Mathematica. She's going to talk about approaches that states will be testing in the state demonstrations to integrate care for dual eligible individuals. And then Randy Brown, who's the Vice President and the Director of Health Research at Mathematica, will provide an overview of the current, albeit limited, evidence about the effectiveness of various approaches for coordinating care. And what we hope to learn from the demonstrations and other current efforts, and also additional research needed to fill remaining gaps. Now, I'm sure that you're all disappointed that Melanie Bella is not able to attend today. Given her important role in the nation's healthcare system as the director of the Medicaid Coordination Office at the Centers for Medicare and Medicaid Services, it's easy to understand why she would not want to be associated with an activity that might steal attention from the Supreme Court on this day. The rumor you might have heard about not wanting to miss a party is not true. But she was able to send along a very capable assistant, Lindsay Barnett. Director Bella, did stipulate, however, that Lindsay must not answer questions about the Supreme Court's decision. So that does not apply, by the way, to the other speakers. Currently, Lindsay is in the Models and Demonstrations Group of Director Bella's office and is the team lead for the implementation of the capitated financial alignment demonstration. Prior to joining CMS in July 2010, she spent 6 years at the Center for Healthcare Strategies. So just before we get started, a little bit of housekeeping. At the conclusion of the presentations, we will entertain questions from both the in-house audience and the webinar audience. If you pose a question, please be sure to let us know your name and affiliation. And we also ask that you limit your comments to just one question, as we want to allow enough time for everyone to get to ask questions of the panel. Also, to help ensure the highest possible sound quality for those on the webinar, we ask that those in the room silence all of your electronic devices at this point. And finally, those in the room, if you look at the packets on your chairs, you'll find materials for today's event and also a comment card. We'd really appreciate your comments at the end of the event, and we can always help make these events better. So now let me turn this over to Jim Verdier. Thank you.
Thank you, David, and thank you all for coming. As this morning's events were unfolding, I was reminded of something Winston Churchill once said about his experiences in fighting in the Second Boer War. There is nothing more exhilarating than to be shot at without result. Had a little bit of that feeling this morning. Okay, let's see if we can get this to move. So what I'm going to do is talk about several things, the characteristics of Medicare, Medicaid enrollees, focusing in particular on the differences between the over 65 and over and the younger dual eligibles. And then in that latter category, focusing in particular on the very extensive diversity of the care conditions and needs that younger dual eligible population has. As you all know, the financing and the coordination of care for dual eligibles is exceedingly complex because that care is funded and provided through two programs that were really never designed to work together, and not surprisingly, they don't very well. But that is changing as a result of the ACA and the establishment of the Medicare Medicaid Coordination Office, and we at Mathematica and the Center for Healthcare Strategies are doing a lot of work with them through the Integrated Care Resource Center, which I'll talk more about in a little bit. So these are the basics on the composition of the dual eligible population. I'm going to go through this pretty fast, and there are a lot of numbers in there. There are citations to where those numbers come from at the bottom of each slide, and then there's sources at the end. So I'm not going to go over a lot of the detail because you can get it yourself as you have time and inclination. But just the basics, about 60% were 65 and are 65 and older, and about 40% under age 65. About over 3/4 are so-called full duals. They're getting full Medicaid benefits as well as their Medicare benefits, and partial duals just get Medicaid assistance with their premiums, Medicare premiums, and beneficiary cost sharing. Comparing the duals age 65 and older to those under 65, the younger duals have similar low income and education levels as you'd expect. They have a lower incidence actually of physical illnesses, but they have a much higher incidence of physical disabilities. We'll get into that in a little bit more in a second. They have much more extensive incidence of mental and cognitive impairment, behavioral health kinds of conditions, and you see the list of the kinds of behavioral health conditions that are common in the under 65 population. They have much lower levels of Alzheimer's and dementia, as you would expect with a younger population, and also, as you would expect, they make less use of nursing facilities. Looking now just at the over 65 population and comparing dual eligibles to the Medicare-only beneficiaries, again, the duals have lower income and education levels, higher incidence of physical illnesses, higher instances of Alzheimer's and dementia and other kinds of conditions of that sort, and as you would expect, higher nursing facility use. Looking in particular at use of long-term supports and services, this is actually the major part of the care that Medicaid provides. And you see for Medicaid, the percentage that are in Medicaid nursing facilities for long periods of time, the portion that are in for shorter periods of time, those who are in other kinds of long-term care facilities in Medicaid, facilities for those with developmental disabilities are the largest portion of that. And then a substantial portion are served in the community, funded by Medicaid, which largely doesn't happen on the Medicare side. Most of that funding is in Medicaid. And the next bullet there shows that, again, the use of those services is much higher among the older dual eligibles. And this looks at the Medicare skilled nursing facilities, the short-term stays after a 3-day hospital stay. And again, the utilization is much higher in the older dual eligibles. The behavioral health conditions of dual eligibles are especially important for the younger duals, those under age 65, but there are also very substantial instances of those conditions for those above 65. It's especially important for dual eligibles because Medicare coverage of behavioral health services is extremely limited. So almost all of this occurs on the Medicaid side, and that has important implications for coordination of care. The costs to Medicare and Medicaid for dual eligibles are shown there. Those are fairly familiar figures, disproportionate cost in both Medicare and Medicaid. These are new data from CMS that I'll talk about more in a bit. But the cost to Medicare and Medicaid in the aggregate are about the same. It shows a little bit different there in the top bullet, but if you look down to the bottom one, that doesn't include what Medicaid pays for Medicare premiums, which is about 5% of the total, so that brings it pretty close to 50-50. And there's, as you would expect, some variation from state to state. And again, this is from this new CMS data source that I'll tell you about in a second. The spending, even though it's the same in the aggregate, the distribution of the spending is very different in the two programs. Medicaid pays for mostly long-term supports and services. It covers some acute care services that are not covered by Medicare, but not a lot. A large portion of Medicaid spending actually on duals does go for payment of their Medicare cost sharing and also for their Medicare premiums. This shows the average annual Medicare payments per dual eligible by service, and this is from Medicare Current Beneficiary Survey, which is where almost all of the Medicare data comes from. And that survey does have some limitations in terms of not capturing all dual eligibles, I suspect, and excuse me, and it also is not reliable at the state level, so you can just get national data out of that. But that again shows the patterns there: very large spending on inpatient and hospital, outpatient hospital services, a lot on prescription drugs, a fair amount on physicians, and less on those other services that are shown there. This is another way of looking at the same data from a somewhat different source, but the story is about the same, but in this case it's juxtaposed with the Medicaid spending on duals as well. And again, the Medicare spending is from survey data and the Medicaid spending is from actual claims data. So that's, in a sense, 100% sample. Prescription drug use, the only data I have on this is from back in 2005 when that was all covered by Medicaid, and Mathematica for years has done a lot of work with CMS on that. But I wouldn't expect the patterns to be very different in the Part D program that now serves dual eligibles. But again, you see that very, very heavy use of antipsychotics, antidepressants, especially among the under 65 duals and especially among nursing facility residents. The major challenges in coordinating care are sort of listed here. Dual eligibles receive almost all of their acute care services from Medicare, and that presents major challenges for people who are in Medicaid-funded nursing facilities because there's just no information on the kind of Medicare services they're getting that's available to Medicaid programs. As I mentioned before, very serious behavioral health needs in the Medicaid population, but the people providing those behavioral health services to dual eligibles know nothing about their Medicare services, what kind of prescription drugs they're getting, what physicians they're going to, black box, they just don't know. There are services that both programs cover, nursing facility, home health, durable medical equipment, and hospice, intersect in exceedingly complicated ways that very few people understand. The Medicaid payments for Medicare premiums and beneficiary cost sharing are very complex to administer, complex for people to take advantage of, and as a consequence, a lot of people who are eligible to have Medicaid pay for their Medicaid premiums or Medicare premiums and cost sharing simply don't sign up. They're leaving a minimum of $1,000 a year on the table just for the premiums by not signing up, but they just don't because it's too complicated, and they got to go to the Medicaid office to do it. And there has been, up until now, an absence of really good data linking Medicare and Medicaid. That has now been remedied thanks to the efforts of the Coordination Office, and they have a national profile and profiles of every individual state that are available on the website shown there. That's the Integrated Care Resource Center site, which is shorter web link than the Coordination Office website, but it's available both places. And Melanie will give you the longer link in her slides where she had more room. But those profiles provide just very, very rich detail, and there will soon be added to the information that's in there a lot of diagnostic information on the kinds of conditions that are especially common among the under 65 duals, but have not been in these linked files before. This is just a little blurb for the Integrated Care Resource Center. It tells you a little bit about what we do for states with the help of the Center for Healthcare Strategies and the support of the Coordination Office. And that's the website for the Integrated Care Resource Center, and states can contact us directly for information and assistance with their dual eligible activities. And those are the sources I used. So thank you.
Thanks, Jim. And good afternoon, everyone. So clearly from Jim's presentation, people who are dually eligible for Medicare and Medicaid have very complex healthcare needs and would greatly benefit from integration and coordination of their healthcare services. To that end, CMS back in April 2011 awarded 15 states with contracts to design new integrated delivery systems and care coordination models for Medicare and Medicaid enrollees. And shortly after, CMS then opened up this financial alignment initiative to all interested states willing to work with them on testing 2 financial alignment models to support the integration of primary care, behavioral health, and long-term services and supports. The 2 models are listed here. The first is the capitated model, wherein there's a 3-way contract between the state, CMS, and health plans to provide comprehensive, coordinated care to Medicare, Medicaid enrollees. The second is a managed fee-for-service model, which pretty much encompasses anything that isn't the capitated model, and this involves an agreement between the state and CMS that would allow the state to benefit from savings resulting from initiatives to integrate care and reduce costs in both Medicare and Medicaid. All states interested in implementing a financial alignment initiative submitted proposals to CMS, and as of May 31st, 26 states had submitted proposals, and they can be seen at the link provided here because I have more room, as Jim had said. If approved for implementation, state programs for Medicare and Medicaid enrollees would be implemented in 2013 or 2014. So the hope of this presentation was just to give you some select examples of approaches states have proposed to integrate and coordinate care. Many of the state proposals that have been submitted are still open for public comment. It's very likely that the state approaches will be changed and refined based on feedback from stakeholders and continued negotiations with CMS. The examples provided in these slides are here just to give you a flavor of what states are considering and in no way reflect final decisions on what states will actually do. So as stated earlier, the goal behind all this work that the states and CMS are doing is to try to move health systems from what states currently have to more integrated, coordinated systems for Medicare, Medicaid enrollees. The table here shows in the left column current systems that exist in states, and those range from ones with no integration to partial integration of services to almost full integration of services, which is rare, but there are examples in Massachusetts, Arizona, and Minnesota. On the right-hand column, it shows where the states and CMS are working to move the health systems, and these would be to systems that are fully integrated under an entity that assumes financial risk, such as the health plan, or through agreements between an accountable entity and providers of services. In some situations, the systems could be a mix of both. The middle column presents some of the strategies that states may be using to facilitate these changes. Strategies include creating new entities to either serve as at-risk entities under the capitated model. So, for example, Oregon plans to launch coordinated care organizations in fall of 2012, or creating accountable entities under the fee-for-service model. So, for example, Connecticut is proposing to use newly formed health neighborhoods as accountable entities. Another strategy for states is to expand on existing entities and programs already in place. For example, North Carolina is planning on building on their medical homes and local networks already in their Community Care of North Carolina program. And similarly, New York has an existing program to coordinate physical and long-term care services in a capitated setting, and this opportunity with CMS would allow them to incorporate long-term services and supports, which are currently under the fee-for-service environment. Another strategy for states is to create new relationships between existing programs. For example, Michigan is building linkages between an existing managed behavioral health system with long-term services and supports. And as always, with the strategy or mix of strategies that states propose to use really depends on what's feasible within that state's context. The remaining slides I have will provide some approaches states are proposing for integration and care coordination to help bring about these health system changes for Medicare, Medicaid enrollees. So the simplest method to integrate services for Medicare, Medicaid enrollees is through a fully integrated model where health plans or entities that assume financial risk are held accountable for ensuring those enrollees receive all the needed services and that all those services are coordinated. Some states are planning to start building this from the beginning, and then other states like Arizona are building on existing integrated systems for Medicare, Medicaid enrollees. There are instances where states have existing programs and delivery systems in place that make full integration of services under a health plan at financial risk difficult or unrealistic. In these cases, states have suggested other ways to integrate services through contractual agreements or other managed fee-for-service strategies. So, for example, Colorado is considering requiring that accountable entities enter into contractual agreements with behavioral health organizations to ensure that those providers are included in the multidisciplinary care team that's going to be providing care coordination. Another approach would be to align financial incentives. So, for example, in a state where there's an existing LTSS system that can't be brought under capitation, the state may tie the accountable entities' quality incentive payments to metrics related to shared accountability with LTSS, or there could be shared savings arrangements between the health plans and LTSS partners around benchmarks such as reduced rehospitalization rates and emergency department utilization. And Oregon is a state that's considering such an approach. The next few slides provide some state approaches to care coordination, and this slide lists some components of care coordination that have been highlighted in state proposals. It's not at all intended to be a full list, but as you can see here, some components include a focus on person-centeredness, use of care assessments, development of comprehensive care plans, use of multidisciplinary care teams, and the inclusion of the client and family in care decisions. Some states appear to be more prescriptive regarding what components of care coordination to include. For example, they may require use of multidisciplinary care teams or site location of coordinators in high-volume practices, or co-location of physical and behavioral health to facilitate service coordination. For example, Illinois may require co-location of physical and behavioral health practices. Other states may give plans more flexibility and place the emphasis on measuring results using, for example, patient experience measures and utilization measures. States are also considering different models of care coordination with different entities designated as the primary care coordinator, though the client is always at the center of these models. For example, one proposed model might have the lead care coordinator residing with the health plan working with the client's multidisciplinary care team. Another proposed model might have the lead coordinator residing with the client's medical home, and then still other states are proposing to allow the client to decide where their lead care coordinator will reside based on their primary service needs. So if you have a person that is very connected to their behavioral health provider, they can then select that provider as their lead care coordinator. And Michigan is proposing to use such a model. States are also proposing using health information technology for care coordination. They may require technology linkages and data sharing between providers, or predictive modeling to identify those in need of intensive care coordination, or use of real-time data, like on hospital admissions and discharges for care coordination. And finally, this slide is just to provide you examples of a couple of other innovative strategies that can be seen in state proposals. I'll highlight one strategy that Illinois is proposing. The state may require health plans to have a SNFist program for nursing home residents. A SNFist is a skilled nursing facility physician or advanced practice nurse who provides medical services and oversees transitions between the skilled nursing facility and the hospital. And the SNFist would work with the members that are at high risk of multiple readmissions to address issues commonly contributing to readmissions. So I hope that I've been able to provide you with a flavor of what states are proposing to do to integrate and coordinate care for Medicare and Medicaid enrollees. As I indicated earlier, many of these proposals are still open for public comment, so I would encourage you to visit that link that I provided on an earlier slide and review some of the proposals and certainly provide CMS and states with your feedback. Thank you.
Thanks, Molly. This talk comes out of a paper my colleagues, David Mann and I, have written for Kaiser Family Foundation. We hope to be able to distribute it today, but a few more tweaks are needed, they say, so it won't be available for a few weeks, but I promise to clog up your email boxes with it to everybody that signed up for the webinar as soon as it's available. The reason for the paper was that a couple of papers have been circulated in the past year that have claimed that Medicare could save $100 billion or more over the next decade by enrolling all dual eligibles in managed care. That seemed a little fanciful to some of us, given that MedPAC's estimates are that we continue to overpay Medicare Advantage plans relative to what fee-for-service costs would have been. And dual enrollees are a very complicated and diverse population, as you just heard from Jim and Melanie, that wouldn't be easy to serve. So Kaiser Family Foundation asked me to write a paper taking a look at the evidence that this claim was based on. So before giving you the overview of what I'm going to talk about, let me first give you a couple of statistics from 2007 data that illustrate the diversity of the dual population. You've already seen quite a few numbers from Jim, so I'm going to show you a couple of different numbers. This slide is based on data compiled by the Kaiser Commission on Medicaid and the Uninsured and the Urban Institute, and an assumption because I couldn't find the exact numbers that I wanted. So, but our first premise is that people who are in nursing homes require a different type of care coordination. They have different needs and situations than people living in the community. And Kaiser and the Urban Institute estimate that if you look at just the 7 million dually enrolled individuals who have full Medicaid benefits, you'll find about 18% are living in nursing homes. Another group that's complicated to coordinate services for is those living in the community and getting long-term support services. That's another 18%. A third group of interest that needs a fair amount of coordination are dually enrolled people with multiple chronic conditions but no long-term support services. They see a lot of physicians, but they have mainly medical needs. And that's another about 26%, assuming that everybody that's in a nursing home or getting long-term support services has multiple chronic conditions. And finally, the remaining 38% has no or maybe only one chronic condition and uses no long-term support services. So you can see that the dual enrollees are a very diverse group in terms of their needs and their situation. Each of these groups has different care coordination needs. Some need coordination only across the multiple physicians that are treating them for their chronic illnesses. Some need care coordination of their medical and their long-term support service needs. Some need coordination of their physical and behavioral health care. And over a third are basically pretty healthy, just old and poor. So with this background information, let me tell you about the rest of the talk. First, we're going to take a look into the claims that enrolling all duals in managed care will save Medicare billions of dollars. What's the evidence for that claim? Next, we'll look at the few plans that have focused exclusively or mainly on dual eligibles in the past and summarize the evidence on the effects that they've had on service use and cost. Then we turn to other evidence from interventions that weren't targeted at the dually enrolled but did serve people with multiple chronic conditions, like over 60% of the dually enrolled have. Then I'll give you a brief summary of what this evidence means for cost savings you might expect from the programs that are devoted to serving the dually enrolled. And finally, I'll talk about the implications that I think the hard evidence has for policymakers. So our conclusion from reading the papers claiming large savings, and by large I mean $10 to $25 billion per year for 10 years, is that there's little or no credible evidence to support those claims. The papers give projections, but they either cite no evidence for the assumed reductions for managed care, or only cite evidence that was generated on very different non-dual populations and was not rigorously done. They also tended to assume reductions in hospitalizations and then assume that all the reductions would translate directly into savings to Medicare without considering the fairly high administrative costs that managed care plans have. They average about 13% last time I looked. The projections are also called into question a bit by the fact that they were produced or funded by the managed care industry, which has a clearly vested interest in promoting this solution. And that'd be okay, but given this vested interest, it would have behooved the funders to have an independent review of the estimates, such as a peer-reviewed journal or hiring outsiders with no stake in the game to critique the estimates, but that wasn't done. And finally, the estimates lack base validity. MedPAC estimates are that there are only about $7 to $8 billion spent on preventable hospitalizations among all duals in a given year. So it's hard to see how Medicare could save $10 to $25 billion a year by reducing hospitalizations, as the papers claim, even if they eliminated a high proportion of the potentially preventable hospitalization. And finally, Brian Biles is in the midst of a paper that's examined data from the 2009 cost report submitted by special needs plans for dual eligibles and shows that their actual risk-adjusted cost for delivering basic Medicare benefits to Medicare Advantage enrollees exceeds fee-for-service costs in the great majority of counties in the country. So plans may be unlikely to be interested in serving dual eligibles in most areas if the capitation is set at a rate that will really generate savings relative to fee-for-service. So given that there's not much evidence to support the claim that whopping savings are available by enrolling 7 million dually eligible people in managed care, what evidence is there on whether any intervention could lower the cost of, serving the dually enrolled while increasing or at least preserving the quality of care that they get? So we examined the evidence for programs that focused on this population, and there isn't much, and a lot of the evidence is pretty weak methodologically, but we did find several fully integrated managed care plans that provided very good care, but in most cases, the capitation rates were set too high to generate savings relative to fee-for-service. And the programs were modest in size, serving a few hundred to a few thousand people per site. This slide shows that the effective programs that we did find. There's Evercare, which serves nursing home residents, the PACE model, a program of all-inclusive care for the elderly, which is essentially day centers for adults needing long-term support services and monitoring, and 3 programs serving a broader population of the dually enrolled, the Minnesota Senior Health Options Plan, the Commonwealth Care Alliance, the Senior Care Option Plan in Massachusetts, and the Wisconsin Partnership Program. There were a couple of programs that appeared to be able to generate cost savings for Medicare on the dually enrolled. One was the SCAN health plan in South California, but that's one of the 2 or 3 areas of the country where fee-for-service costs are extremely high. And then there's the disability care plan in Massachusetts that looks like it could generate savings, but that's a small plan serving about 400 people with quadriplegia. So this limited bit of evidence on programs designed for duals doesn't suggest that big savings are likely there either, even from well-designed programs with good quality. But there are other programs that serve complex but mostly non-dual patients for which there's evidence that savings are possible, and which might work for dually enrolled people with similar conditions. So we looked at these fee-for-service-based Medicare care coordination programs that were designed for Medicare beneficiaries with chronic illnesses. And another option that's being considered, as Melanie pointed out, by some states for the dually enrolled. We found several pilot or demonstration programs with very strong evidence from randomized controlled trials that did succeed in decreasing their enrollees' need for hospitalizations among the subset of their enrollees that were at high risk of hospitalization. These programs included the GRACE model, that's geriatric resources for the assessment and care of elders. Also, 4 of the 15 demonstration programs in the Medicare Coordinated Care Demonstration Program, and the Massachusetts General Hospital Care Management Demonstration Program for high-cost beneficiaries. And 3 or 4 of these 6 programs eventually produced net savings by decreasing hospitalizations enough to offset their costs. The others were essentially cost neutral, but it took a few years of learning and behavior change to get to these cost savings. And while there were these 6 success stories, there have been a fair number of other care coordination programs, including in these same demonstrations, that were not successful in decreasing preventable hospitalizations. So what are the features that these effective care coordination programs have that distinguish them from the ones that weren't successful in decreasing hospitalizations? They're described in a paper that my colleagues and I published in an issue of Health Affairs earlier this month that came out that showed that in successful programs, care coordinators had the following characteristics and features that were not present in the other less successful ones, unsuccessful programs. First, they had frequent face-to-face contact with patients during the first year to build trust and rapport with the patient. Second, the successful programs tended to build strong support with the patient's primary care physician through routine contact at the hospital or clinic or the physician's office or a prior relationship. They don't work in the doctor's office or for the physician's practices, but they were often on the same campuses or in clinics. They use structured behavioral change techniques as well, such as motivational interviewing and readiness to change models to help patients overcome their barriers to adherence to recommended self-care, medication, diet, exercise. The fourth characteristic was that care coordinators know when fairly quickly when a patient is hospitalized and then plan and implement a safe transition from the hospital to home to minimize the risk of short-term readmission, which affects about 20% of all Medicare beneficiaries who are hospitalized. Fifth, the care coordinators acted as a communication hub, trying to facilitate the exchange of information between the primary care physician and the specialist that the patient saw, and between medical professionals and the patient and his family, his or her family. And the sixth feature was they had reliable information about patients' medications, both what was prescribed and what was taken, and had access to a pharmacist or a physician who they could consult with about medication issues that were beyond their own knowledge. These weren't the only features of the successful care coordination programs, but they all depended on excellent care coordinators, for example, and they would all say that. But these were the features that were common in the successful programs, but not in the unsuccessful ones. So based on all this evidence, what can policymakers reasonably expect if they implement various options? First, at best, relatively limited savings are likely to be achieved, not the hundreds of billions of dollars that have been projected by some. And even that may take a few years to materialize if you rely on fee-for-service-based care coordination. Second, we should expect pretty unfavorable results if the same model is used for all dual enrollees. As the first slide showed, there are some very diverse groups among the dually enrolled with very diverse need for services and need for coordination of these services. So Evercare might be a great model for those that are nursing homes, but for people that are needing long-term support services in the community, they may need a program like PACE or the Senior Care Options programs or one of the other small managed care plans that focus on the dually enrolled. And fee-for-service-based care coordination programs may be the most cost-efficient solution for people with chronic illnesses who don't need long-term support services. The third expectation is that if you implement these effective programs, dually enrolled people should benefit by being able to avoid a sizable number of hospitalizations. That's good for them, it's good for their families, and it's good for costs. And fourth, there may be some additional savings for the federal and state governments and of great benefit to the dually enrolled people if the programs can decrease their need to enter a nursing home, but there's not much good evidence yet on whether programs can accomplish that. So the implications of these findings for policymakers who want to find a way to decrease Medicare costs for this high-risk, expensive, vulnerable group of dually enrolled people. First, if you go for a capitated solution, you have to set the capitation rate at a level below what the people would have cost if they were in fee-for-service, Medicare and Medicaid. Seems obvious, but it hasn't been done yet in most places, and it's the only way to guarantee savings. Second, you need to make sure that the risk adjuster is adequate to decrease the likelihood that plans can benefit and turn federal savings into losses by enrolling people with high capitation rates but low need for expensive services. And that's likely to mean separate models for people who need long-term support services, at least on the Medicaid side, and maybe on the Medicare side as well, since several studies have shown that risk adjustment based only on diagnoses tend to underpredict Medicare costs for people with functional impairments. But based on Brian Biles' work and the past history of the Medicare managed care program in general, you might expect few takers in many market areas if you choose a managed care approach and set the capitation rates low enough to generate meaningful savings relative to fee-for-service. On the other hand, if states choose or offer a fee-for-service-based care coordination approach for the dually enrolled, they should require the plans to have features that have been shown to be associated with success in decreasing hospitalizations. They also have to pay a care coordination fee that's less than the expected Medicare savings in order to generate net savings, and they need to monitor the effects on cost to ensure that they're actually realizing these expected savings. Finally, regardless of the approach taken for serving the dually enrolled, to achieve savings and improve the quality of care that they get, we need to focus the program on high-risk cases, not the 38% who have neither multiple chronic conditions nor long-term support service needs. We need to monitor the effects on quality of care of these programs to make certain that any monetary savings don't come at the expense of these extremely vulnerable people. And third, as the programs roll out, we need to have in place a strong process for identifying what's working and what's not, and how what does work best differs for different subsets of this very diverse enrolled population, so that we can continue to improve care for dually enrolled people and generate some savings for Medicare. Thanks. Dave?
Thank you, everybody. Before I turn it over to Lindsay, I would just want to thank the speakers for staying on schedule. In fact, they're a little ahead of schedule, so we need to have plenty of questions. So those of you who are on the web, you can start putting your questions in now. Make sure you include your name and your affiliation, and we'll look forward to hearing your questions in a few minutes. Lindsay?
Good afternoon. Thank you all so much for having me. Melanie Bella does send her apologies for not being able to join you all today, but given the exciting events of the day earlier, she was understandably unable to be able to make it out of kind of meetings and planning and discussions to be able to be here. So, but we want to thank Mathematica for providing such a comprehensive overview of the population and the challenges and opportunities that really face both state and federal policymakers and others in terms of trying to improve the quality of care for this population. And certainly, I want to echo a lot of what we heard today. That a lot of the information provided, really all of the information provided, is certainly consistent with the priorities of our office. And for those of you that are not as familiar with the Medicare/Medicaid Coordination Office, we have the luxury of being able to focus solely on this population every day. We really do eat, breathe, and sleep Medicare, Medicaid enrollees, the challenges that are facing them, and working on trying to come up with strategies and ways to really improve the quality and cost effectiveness of care that they are receiving. So I thought what I would spend the few minutes that I have with you all today doing is just to highlight a few of the opportunities that we see for improving care for the population a little bit, and sort of how they tie into some of the things that the speakers have talked a little bit about. Certainly one of the greatest opportunities and most immediate opportunities for improving care for this population really has to do with better access to data, and Jim did a great job of highlighting the many of the challenges that currently face policymakers and researchers and others interested in working in this environment around the lack of data that really has on sort of the full picture of the information and the ability for people to improve the coordination of care for dual eligibles. Data and analytics is something that is very near and dear to Melanie Bella's heart and to our hearts in the office, and something that we take very seriously and are working on very hard. Not only the state profiles, which Jim mentioned, which we were very excited to launch just recently after several years of hard work in terms of trying to do that analysis. We have also, in the last year or so, been working closely with a number of states on trying to give them better access to Medicare data in general, so that they can do some more linkages at their own with their own Medicaid data, and really be able to use that information to provide better care coordination to individuals. And so I think at this point we have been working with, in the neighborhood of 25 different states around getting access to both historical Medicare A and B data as well as Medicare Part D data, so that they can really have a full picture of what the population is experiencing in their respective states, and being able to use that information to really help develop programs that will better coordinate care, and to arm care coordinators and providers who are really doing the on-the-ground work in order to help them be able to better target care and resources. So certainly, while this may not be as an exciting or sexy idea, it's one of the kind of quickest ways that we can really try to provide better tools to those who are working on the ground today and trying to improve the care for this population. Another opportunity that we have been very much focused on, given our name especially, is really trying to align the two programs, Medicare and Medicaid, to help them work better for the population. As Jim indicated, these two programs were not designed to work together, and so they don't kind of on a day-to-day basis. So one of the things that we are very much charged with is trying to come up with ways that we can help individuals by working through the differences between the two programs. One of the things that I was struck by from Melanie's presentation was in her articulation of the various approaches that states are trying to test and move forward with in terms of improving care for the population. I think she indicated that the health plan approach or capitated approach might be the simplest approach, and certainly it is the most straightforward approach. But as we think about how you actually bring about Medicare and Medicaid, two very separate programs, into one entity being responsible for them, there's a lot of challenges that currently exist, because the two programs have their own set of rules and regulations, and health plans today who have been trying to do this work have certainly faced a number of challenges in how you actually kind of bridge the gap between the various administrative requirements and financial streams of funding and all of the things that make it a challenge. So that is, not surprisingly, one of the areas that we are focused on a daily basis, both in terms of the financial alignment demonstrations, which Melanie discussed quite a bit, and looking at the state programs and how we can try to integrate both financial incentives as well as administrative efficiencies that we think will ultimately help reduce confusion among the beneficiary population and really help everyone in terms of trying to provide better care for the population. We've also have been working over the last couple of years, sort of leading up to some of the demonstration work on our program alignment initiative overall, which was meant to catalog various places where the two programs conflict or are kind of bump up against each other in its simplest form, to try to figure out ways that we can work, internally with our colleagues in the Center for Medicare and the Centers for Medicaid and CHIP Services to try to come up with ways that we can really do some streamlining of those types of approaches. And then I think the other opportunity we see in our office for improving care for the population really has to do with the testing of new models through demonstrations. And I think to Randy's point, certainly we recognize that there really is a need for looking at multiple models. A one-size-fits-all approach is not going to work for the population for the variety of reasons that the speakers indicated today. It is a very heterogeneous population. There are a lot of different kind of needs and an ability to be flexible in terms of accommodating care models that will meet the various needs of these individuals. And so we've been trying to look at that in a variety of ways. Certainly, in thinking about the state demonstrations that we have been working on, most immediately or most recently, we have tried to come up with two broad opportunities models: a capitated model, a managed fee-for-service model that would really be able to be flexible to kind of reflect the state variation that currently exists on the Medicaid side with various delivery systems and priorities and experiences. And because we have put forth general parameters around each of these models, there is some standardization to a certain extent across as a foundation, but there is flexibility for states to be able to target various populations, to be able to hone in and develop certain care models that really speak to those populations. And then as you take a look at a lot of the proposals, or many of the proposals that are posted online, you'll see that states really are, even if they're looking at a broader dual eligible population, have started to articulate various ways of trying to stratify to get at those highest need individuals and targeting more high-touch intensive care coordination resources to them, so that they can try to have, recognizing that there are differences in terms of the needs and and what will work in terms of being able to improve the care for the population. In addition, we're not just focused on state-based models. Randy talked a lot about the promise of reducing potentially avoidable hospitalizations. We do have another program that was recently announced that is focused on the nursing homes, individuals who are residing in nursing homes, and the opportunity for reducing preventable hospitalizations there. So we really are trying to look kind of at a broad base of opportunities in terms of trying to identify models that will really speak to the population and the various subsets of the population. And going along with that certainly is the importance of creating that evidence base. And Randy is right, there really isn't a lot of rigorous studies that we can point to say these models work or these models don't, and to be able to scale them nationally so that they are so that more individuals have an opportunity to benefit from them. Evaluation is going to be a key component in all of the efforts that we do, and so certainly as part of the financial alignment demonstration and the state demonstrations in general, rigorous evaluation will be a key component of that, so that hopefully over time we will be able to have a much more rigorous evidence base to point to in terms of what models work and what aspects of those models work for various portions of the population, so that we can hopefully prove that that these types of coordinated, integrated systems really do result in better health, better care, and lower cost or improvement for the population. So that is a very quick overview of where we are in our thinking, and certainly I think gets at a lot of what the speakers today mentioned, and certainly a lot of work to be done, but it's an exciting opportunity, and we're looking forward to continuing to do that work. So Thank you.
Thank you, Lindsay. Okay, I think we're ready for questions. If I could get the speakers to turn on their table mics. And let's see if we can get a question from the web audience first, Jenna.
Okay, and I think this question will go to Randy in regards to his comment that early demonstrations use the same model for different populations with different costs. And the question is, has anyone looked at the trajectory of costs and care needs for individuals over time? Does care management prevent or delay decline? And the questioner points out that much of the data here seems to be point in time.
Well, it's not exactly point in time. I mean, some of the care coordination studies were done over a 6-year time period, so, but it wasn't, we didn't focus on looking at how effects changed during the first, second, third, fourth, fifth years. But it wasn't just a flash in the pan. Most of the, I mean, there's not many studies, period, so, you know, hoping to find ones that that actually look at the how the effects vary over time is even scarcer. So there's not much. There's still that's just one of the many areas there where we need more evidence and better evidence.
For those of you in the audience, if you have a question, put your hand up, and Allison will bring the mic around to you. Don't be shy.
Thanks, Allison. Hi, I was thinking that as you talk about dual eligible...
Name and affiliation.
Oh, sorry. This is Craig Thornton from Mathematica. As you think about dual eligibles, sometimes dual seems to be a way undercount, that, you know, these people may be getting SSI, they may be getting DI benefits. Within Medicaid, there may be, you know, carve out for behavioral health. I mean, the number of programs, you know, the housing allowances, you know, the number of programs that may support many of these folks seems to be enormous. And so in some sense, is there even any data that you could say of how many, you know, from the surveys or things, how many kind of programs these people are involved with, and how much beyond just Medicare and Medicaid? I mean, that's complicated enough, but it seems like in many cases it's only scratching the surface.
We want to take that.
Okay, this
Wait a second.
Not working.
There it is.
Okay, it works. This is Jim Verdier, and everybody looked at me because I'm not shy about answering questions that I don't know the answer to. There are some deficiencies or limitations certainly in the survey data on dual eligibles on the Medicare side, because it's very hard to get a full sampling in surveys of people who for whom you don't have good contact information, good phone numbers, have very low levels of education, sort of living alone, or maybe not even in their home. So there are inevitable undersamples there. In terms of the actual enrollment of people in Medicaid or Medicare for services that they really need, I don't think there's a lot of that. If you really have the kinds of serious physical illnesses and chronic diseases that would make you eligible for either Medicaid or Medicare, the first time you go to the hospital, they'll figure out how to sign you up so they can get reimbursed. The part of the dual eligible population that really, I think, does not include all of the people who are eligible are those that I mentioned earlier, for whom Medicaid pays only for their Medicare premiums and cost sharing. And there's very substantial under-enrollment in that. Maybe, you know, there at least 30 or 40% of the people who are eligible don't sign up. Then in terms of Craig's very good question about how do we know what other kinds of services these people are getting or need and are not getting, housing and other kinds of services, I don't know of any surveys that really capture that, but I'm sure there must be. It's obviously not captured in the Medicare current beneficiary survey because they don't ask non-medical questions. But I'm sure that there must be some surveys out there that might be looking more broadly at people's service needs. But then the issue is how many dual eligibles are there in those samples, and I just don't know.
There is a new survey that I just heard about yesterday that the public use file is going to be available this fall, NTOPS or something like that, that focuses on people with impairments. So maybe that may be a source.
Another question? Jenna from the web?
Sure. So what merit is there to the premise that dual S&P costs are higher than fee-for-service costs because of the additional benefits that are included?
It's true that they don't pay any, let's take Medicare services for starters. It's true that they don't pay any deductibles, co-insurance, but then most Medicare beneficiaries have supplemental to cover that too, so that's maybe not a reason why they don't use as much Medicare services, but why they use more Medicare services. They also have a lot higher incidence of chronic illnesses, which is what you would expect to be associated with higher use, so that's a pretty objective measure. On the Medicaid side, there are a number of studies that have shown that there are a lot of people that would qualify for home and community-based services that don't get them. So, if anything, I don't think that's. I mean, obviously, if you took away the benefit, they wouldn't be spending the money. But it's not that they don't need those services, or that even all the people that do need them or qualify for them actually get them. And nursing home care, well, nobody goes to a nursing home that doesn't want to go to that can possibly avoid it, and their families can avoid it. So,
I would just add to that a couple of points. First of all, overpayment of managed care plans in Medicare is not limited to special needs plans. All Medicare plans are overpaid, and that is gradually being sort of ratcheted down as a result of the ACA, and special needs plans are paid in exactly the same way that other Medicare Advantage plans have. And if you look at the actual bids that the plans submit, which are their estimates of how much it would cost to provide the services, they are now in Medicare Advantage on average below 100% of fee-for-service. So it is possible to achieve those kinds of efficiencies in the aggregate. It's probably harder for special needs plans because the population itself may have more accumulated unmet needs. They may not have sort of education levels and family support and other kinds of characteristics that may make it easier to manage their care more effectively. They have more serious and complex both physical and mental and behavioral health needs that also make the challenge of coordinating their care and getting the reductions in avoidable hospitalization use and emergency room use and more appropriate use of prescription drugs. It makes it harder to accomplish that. There are more opportunities to accomplish it over time, but it does take time, and it's not the work of a moment or the work of 6 months or the work of a year to sort of change the cost trajectory for that very complex population. That said, however, I think anybody who spent their lives in Medicaid would be surprised that Medicare was paying more than 100% of fee-for-service, because the rule in Medicaid is you pay 95% of fee-for-service, and that's the drill. And there are a whole lot of health plans who are happily doing business under those rules and making a lot of money and probably providing pretty good care.
Another question? Everybody in the room asleep.
Dave Wittenberg, Mathematica. I'm struck by the diversity of the population, and it strikes me that you've got a very diverse population with very diverse needs, and a small portion of the population that's really driving the costs, and they live in different states where the environments are very different. And so I'm curious of how you design a demonstration to target those populations that would be of sufficient size to be convincing.
So, how would you design a national demonstration given the state differences? Is that the? Yeah, well, you can just market stuff. Well, we've already got the things going on at the state level, and since states control Medicaid, then I think you have to start there. And within any sizable state, you're going to have a fair number of people falling into. I mean, none of those subgroups that I'm listed out are small. They each account for at least a quarter of the population of dually enrolled. So, and I think also the solutions tend, for at least some of the people with the highest cost, tend to be relatively small plans. So you're going to have a lot of. Now they may be all under the same umbrella. I mean, United could have plans all over the state or whatever, but the ones that seem to be effective are ones that are small local plans.
Jenna, do you have another one? Actually, go ahead, Allison. Maggie.
Hi, I'm Maggie Colby, also from Mathematica. Randy, I was looking at your list of the different features of programs that were successful in care coordination, and it occurred to me that some of them really require a fair amount of effort from beneficiaries, either the monthly face-to-face contact or behavioral or behavior change techniques, and some of them seem like they might be the types of things that you could accelerate primarily behind the scenes with better health IT so providers can see the full range of data on folks. Do you have a sense of, well, I guess one, for the things that did require more beneficiary participation, were those things that the beneficiaries opted into? Like they chose to participate in some sort of care coordination demo? And then the second question there is, does it seem like people are sort of tending toward these more time-intensive things that require a lot of beneficiary engagement, or more toward the health IT-driven types of care coordination improvements?
Well, that's a good question. Basically, there are the two sides. Beneficiaries, in order to succeed, it seems like both sides have to be engaged. You have to change patients' behavior, and so a lot of times they're not adhering to things that physicians tell them to do, and take the medications and everything else. Sometimes because they don't understand. Sometimes there's other barriers, whatever. And then there's also the coordination of information which you can get from the HIT. When we looked at the demonstrations, one of the things we looked at was to see whether the ones that had a strong HIT program were more effective, and that was not one of the features that distinguished the successful and unsuccessful programs. So it really seemed like this kind of one-on-one engagement with patients was what seemed to matter the most. The other thing is, in fee-for-service, to try to come in from the outside as a care coordinator and tell a physician that they're doing something wrong isn't going to be very effective, and so they had the effective ones had to figure out ways that they could be seen as a benefit to the physician without taking any of their time. And so just calling the offices to transmit information, make sure that it got exchanged, that was helpful to them and didn't require the physician's time. They could be talking to the front desk and things like that. But I don't think it's most things are going, just a pure HIT solution might help physicians get some information into their hands better, but it isn't going to be all that effective without the patient engagement. These were programs that people enrolled in, but but that's okay, because I think you're still going to have the issue of, even if you did a population-wide thing, only the people that are willing to enroll here are the ones that are going to be influenced by an intervention like this. They're just not going to want to play. So,
Jenna?
You can't escape the ACA comment. I just have one that I think is appropriate. So for the medical cost to administrative ratio, the commenter is pointing out that, I believe, Randy, you said 13% was typical. And the questioner is asking, or is commenting that this seems low in comparison to the 80-20 incentive for rebates under the ACA. Do you have any comments on that?
Yeah, this is not my area of specialty. The 13% I'm quoting is one from that came up from the Academy Health meeting. Just to Brian Biles, he said that's the average loss ratio is 13% for the Medicare plans for providing basic benefits. So, yeah, I think that the stuff that I have done years ago, the range seemed to be between 10 and 20%, and so this falls in that range, but it's towards the upper end. So. And Brian did say this was the average, so there are a number that are below the 87%. So,
Another one in the back.
Good afternoon. Excuse me. My name is Gene Axis. I'm with AARP, Office of Policy Integration. And first of all, thank you so much for hosting this session. I found it to be extremely insightful. My question is one around cost savings, particularly with the demonstrations, and how states are and CMS plan to calculate or demonstrate cost savings, particularly for the managed fee-for-service model. And then, as a follow-up to that question, in looking at some of the proposals of the states submitted to CMS, is there or are there any indications as to how the states plan to utilize those cost savings?
So unfortunately for you, you have the capitated model person here as opposed to the managed fee-for-service model person. So I don't know how much I can really speak to the details of exactly how the cost savings is going to work under the managed fee-for-service, although I know that there is a lot of work still kind of underway, both from a CMS perspective to try to set kind of a national methodology for how that will work, and then obviously with each individual state. But my understanding is that there will be, minimum savings rates that the states will have to be able to show savings through, and then we'll have the opportunity to keep some of those savings beyond that minimum savings rate, assuming that they are able to hit certain quality benchmarks. So certainly, the goal of the demonstration is not just to save money, but really, more importantly, to ensure that we're improving the quality of care for beneficiaries. And so that will be a huge factor in terms of how the sharing and the savings will work on the managed fee-for-service side.
I can give you a non-authoritative elaboration of the managed fee-for-service approach, which is, Lindsay said, is still not fully out to the public in a detailed form, but just conceptually the way the states that we're talking with, North Carolina and some of the others, are looking at it is they actually face a substantial dilemma because, as Randy suggests, you have to make investments in care coordination, infrastructure and staff and capabilities before you start seeing the savings in avoidable hospitalizations and things of that sort. So all of the states face the challenge of how can they fund that upfront support, how can they fund incentive payments for physicians and others to do the sort of extra things that are needed to make this work. And the savings on the Medicare side in the managed fee-for-service model would not come until the second year, after there's a year's worth of experience under the model to determine whether the savings are real or not, or just random events. And so it's kind of built, that dilemma is built into the managed fee-for-service model. There's got to be some way of getting those savings early upfront from somewhere. They're not going to be available through the demo. They're not going to be available for Medicare from Medicare right away. And states like North Carolina that have a very robust care management infrastructure already in place and working very well for their Medicaid-only population, including a lot of people under 65 with very serious chronic illnesses and disabilities that are virtually indistinguishable from those of duals. They have the infrastructure there, and so it's just an incremental cost, but it's a cost. And you've got to figure out some way of getting that upfront capacity in place before the actual savings are actually going to appear in the managed fee-for-service model. Is that fair, Lindsay?
Yeah.
Okay.
Yeah, and this is Melanie, just to get at that second question as to how states might be actually using some of the cost savings. I know that there were a couple examples, especially on the capitated side, of potentially savings being passed on to health plans so they can provide some additional supplemental services like dental services and things of that sort.
Got a hand over here? Yeah.
Hi, this is Lori Ackman from GAO. Hi, Jim. My question is there any idea what kind of interest there is from health plans in participating in these demos, considering that there is going to be a lot of requirements on them and they might not get, with the capitated demonstration, the savings are built into the payment, so they're not going to be getting more than fee-for-service like they do with traditional Medicare.
Sure. I mean, I think we recognize that this may not be the demonstration or the opportunity for every plan in every market, and there may be, as Randy pointed out, markets where this may not be as enticing for plans as than in others, and that's okay. But I think on the overall side of things, we think there will be a lot of interest because although they may be kind of savings built into the capitated rates that plans will be receiving, they're going to get a lot of additional kind of flexibilities in a way that is not currently available. The types of administrative efficiencies that I kind of mentioned or previewed earlier are things that they may not be able to have today. So having to have a more streamlined set of reporting requirements and a streamlined set of grievances and appeals processes and trying to have a single system or getting closer to having a single system with a single set of rules that plans will no longer have to navigate kind of the two systems, we hope will result in some administrative efficiencies for them. And we also think that there's an opportunity for having additional enrollment in these programs through some of the state requests for passive enrollment and things like that will hopefully create an interest among plans as well. So it may not be something that appeals to every plan, but we think that there will be sufficient interest.
Yeah, and let me elaborate on that a little bit because I read a lot of things that come in from Wall Street analysts and announcements of conferences and things of that sort. There's just enormous interest in the dual eligible population in the managed care industry as a whole, because that's one of the few major growth areas, number one, and number two, the kinds of integration activities that are needed for dual eligibles are the sorts of things that good managed care organizations are good at. Now, a lot of them may not realize how different the Medicaid population is from the Medicare population that they're familiar with, or vice versa. A lot of Medicaid specialized plans may not realize how complex it is to also be in the Medicare business. A lot of plans may not realize how different coordinating long-term supports and services is, and dealing with people in nursing facilities is, from dealing with the populations they're accustomed to. There are a number of plans that have operated in both the Medicare and the Medicaid markets on a national basis. There are a number of plans that have had experience that are, local plans, Minnesota and some others, so they kind of know what to do and what they're getting into. There are other plans that don't have the kind of capacity right now that they would need, but there are very, very major revenue opportunities out there for plans that do this right and are able to persuade states and CMS that they can do this right. And there is, through the coordination office in the demonstrations, a pretty elaborate process to screen plans and determine whether they are ready or not, to make sure that the plans who do actually get into this business through the financial alignment demonstrations are plans that know what they're doing or can figure out how to what's needed over a period of time. And a lot of these are not going to implement until January 2014. So there's time to develop that capacity, but there is enormous interest. Some of it might be uninformed or misguided, but at this point, but a lot of it is out there.
Yeah. And they haven't seen the capitation rate.
Yeah.
Hi, I'm Ellen O'Brien from MacPac, and I guess I have a question for Randy Brown or other evaluators up there about whether you have concerns about the capacity of CMS to undertake a meaningful evaluation of the financial alignment demonstration, the capitated model in particular, and if you could talk a bit about the evaluation strategies you think would have to be deployed in light of the fact that states propose to enroll all or nearly all of their full benefit duals into the demonstration. Does that present a particular challenge, or what are the key challenges?
Well, I can't do RTI's work for them, but they're the ones that are hired to do the evaluation, and they do.
Anybody from RTI here?
Have their work cut out for them. It's not easy, and so I don't think this is the right forum to talk about evaluation designs. There's a lot of different things that could be tried, and it would be, but to the extent that they can, and I don't know how much control the evaluator has either, doesn't sound like much. So to the extent that they can do phased-in things in certain counties or certain areas, that would be far better. I think it would be better to go slow and learn than to try to throw everybody in there at once and possibly suffer the consequences or have plans dropping out and people having to switch out of plans and change providers. So I would hope that they'll take a gradual approach rather than think that they're going to generate huge savings from day one on every dual in the state.
Jenna, any more from the web?
Staying on the topic of evaluation, the one question is, what are thoughts on requiring a lock-in period for beneficiaries who join DSNPs and or demonstration programs to ensure meaningful results of care coordination or potential cost savings?
So in terms of enrollment opportunities under the demonstration, at this point we have, offered the opportunity for states to request a passive enrollment option, which would, allow for individuals to be made aware of their choices, and if they made no active choice, to be enrolled into a demonstration with the ability to opt out at a later date. At this point, those are the types of kind of flexibilities that we're offering under the demonstration, as opposed to any sort of lock-in or other type of mandatory enrollment on the Medicare side.
They can opt out at any time.
Right, exactly.
Okay, so there's no limit on
it.
Okay,
no, the special election period and that duals have under Medicare will continue under the
and if they sign up themselves, they voluntarily sign up, are they locked in then, or they can also, those people can also exit at any time?
They can opt out at any time.
Okay, yeah, that's good. That's the way it should be.
And I think actual experience in a lot of the plans that did get passive enrollment back in 2006, and there were almost all the plans in Arizona did, in Orange County in California and San Mateo, their experience generally was that after maybe a little bit of turmoil, which occurred in a lot of places in early 2006, people pretty much stuck with the plans that they were in. There was just not a lot of movement from one plan to another. There was some movement from a plan back into traditional fee-for-service when that was possible, but sort of moving from one plan to another. You hear about it anecdotally from the plans, from the marketers, because their whole lives turn around whether 2 or 3 people move in the course of 2 months. But really, if you look at the data, they just don't turn over that much.
Yeah, but that's a great safety net for the beneficiaries to be able to opt out or leave at any time if they don't like it. That's the way managed care plans for Medicare started out, and then they got into a lockout, and I think they're backing away from that here. So,
one more in the room here. Yeah.
Thanks. Jesse Crosscall with the Center on Budget and Policy Priorities. I just want to be clear about that last point, because a lot of states are proposing lock-in periods for 3 months, 6 months. So you're saying that you're not going to allow that?
We're saying that the passive enrollment is what the option is in terms of enrollment flexibilities at this point. So.
But once the enrollee's in a plan on January 1st, what are their options from there?
They have the opportunity to opt out. So we're not, I mean, the passive enrollment option with the ability to opt out at any time is what is currently being proposed and considered as part of the demonstration.
Okay.
Any more? All right, well, you've been a very good audience, and before you go, and if there's any justices left on the phone, I want to let you know that our next forum is on October the 4th. We're going to take a summer vacation, and I hope to see some of you in the fall. Thank you very much.